Hi guys, in this lecture we are going to talk about the different treatment options available for acne vulgaris. So hopefully at the end of this lecture you should be able to describe the pathophysiology of acne vulgaris, identify the suitable treatments for acne of different levels of severity, describe the mechanisms of action and adverse effects of the drugs used in acne treatments, relate the mechanisms of those drugs with the hallmarks or the classic features of acne. Now, a bit of introduction about acne. Acne is a very common skin condition affecting roughly 1 in every 10 individuals across all age groups. Some people are particularly prone to acne. For example, men in general have more oily skin due to more active sebaceous glands. The skin oil or sebum is an important energy source for the acne-causing bacteria that live on our skin. Family history is another important risk factor for acne as well. So having good skin is like hitting the genetic jackpot. So if your parents are acne prone, then it may pay for you to take extra care of your skin to prevent acne breakouts. Alcohol consumption has also been linked to increased risks of acne. As you all know, acne can have some negative psychosocial impacts as well. Acne, especially those severe lesions that leave ugly scars in their wake, can make you lose your confidence, feel unattractive, and have a low self-esteem. An interesting fact, some people are genetically prone to getting unsightly scars, something to do with the post-acne healing process, especially the role of fibroblasts. Acne can cause significant anxiety as well. Those suffering from acne may experience high levels of stress and anxiety, and this can form a vicious circle where acne increases stress levels that can in turn worsen existing breakouts. Now, let's look at the pathophysiology of acne so that you can understand the treatments better. There are four classic features or hallmarks of acne. Firstly, increased sebum production creates a favorable nutrient-rich environment for Cutibacterium acnes, the acne-causing bacteria, to grow and thrive. The bacteria metabolize sebum into glycerol and fatty acids. Now, some fatty acids or the bacteria per se can trigger inflammation, attracting immune cells to the follicle and causing significant damage. Ultimately, the product of the inflammation is the annoying tiny bump you normally see on the skin surface. Hyperkeratinization also contributes to the formation of acne lesions. Basically, there is hyperproliferation or overgrowth of keratinocytes and overproduction of keratin. Together, they form a sticky layer that covers and blocks the openings of hair follicles or skin pores, trapping sebum inside where it's normally expelled to the skin surface. Again, Cutibacterium acnes loves the trapped sebum. The bacteria feed on the sebum and thrive. Acne causes two major types of lesions, i.e. inflammatory and non-inflammatory. Non-inflammatory lesions are considered milder in severity and include blackheads and whiteheads. The difference between these two is that the opening of a hair follicle in a whitehead is blocked by overgrown skin cells, but that in a blackhead is not. The difference between the three types of inflammatory lesions is that a papule is not filled with pus, whereas a pustule contains pus or fluid in its center, and a nodule or cyst is a severe lesion formed by a mixture of pus, bacteria, sebum, and dead skin cells. This table shows you the criteria used to assess acne severity, called the Comprehensive Acne Severity Scale, according to the number of lesions and the area affected. As you can see here, acne can be divided into 6 categories of severity: clear, almost clear, mild, moderate, severe, and very severe. Of course, as pharmacists, we are not typically supposed to diagnose a disease, but I think this may be useful in the community setting where you may have to entertain and assess customers with acne and know when to refer them to a dermatologist. Shown here is an overview of the treatment options available for acne. As you can see here, there is kind of a progression of the treatment options according to acne severity. For mild cases, a topical retinoid or benzoyl peroxide alone is sufficient. But as you go up the scale in terms of acne severity, a combination of topical agents is required, such as benzoyl peroxide, retinoids, topical antibiotics, azelaic acid, or salicylic acid. If these don't work, an oral antibiotic should be added. Unfortunately, for severe acne, the only treatment option available is oral isotretinoin, and at this point, the patient should be referred to a dermatologist. Retinoids are a group of vitamin A related compounds that are very effective against acne, particularly oral isotretinoin. Although guidelines recommend that isotretinoin should be reserved for severe acne, it is commonly used off-label in patients with mild to moderate acne, given its efficacy and the psychological stress that acne can cause. So you can clearly see here the mechanisms of action of retinoids is quite complex, but it would be easier to understand if you kind of tally the mechanisms with the pathophysiology of acne. At the molecular level, retinoids work quite similarly to some of the drugs we have covered in the previous lecture, i.e. they alter gene transcription patterns. In the systemic circulation, retinoids bind to retinol binding proteins and are taken up in this form into target cells. Once inside cells, retinoids are dissociated from the proteins and are converted first into retinaldehyde, then all trans retinoid acids, which bind to cellular retinoid acid binding proteins too. And finally, they translocate into the nucleus and activate the retinoid acid receptor and retinoid X receptor to alter gene transcription. Now, at the cellular level, topical retinoids and oral isotretinoin work quite differently. And isotretinoin is the only agent that tackles all four hallmarks of acne. The differences in the mechanisms of topical versus oral retinoids are listed at the end of this PowerPoint presentation. For the mechanism of action of isotretinoin, firstly, it reduces sebum production by shrinking the sebaceous glands. Also, it decreases keratinization and unclogs the skin. By changing the expression levels of genes regulating immune function, isotretinoin has potent anti-inflammatory effects. By changing the microenvironment within a skin follicle, isotretinoin reduces colonization by Cutibacterium acnes. Both topical and oral retinoids have beneficial effects on post-acne scars. They increase cell turnover or renewal, and this helps remove the melanin pigments deposited in the skin and decrease hyperpigmentation induced by inflammation. They also increase collagen production, and this promotes better post-acne healing and minimizes scar formation. FYI, this is why retinoids have also been studied quite a bit for their anti-aging effects. Isotretinoin obviously is more effective than topical retinoids, but it also causes much more severe adverse effects. It's widely considered by dermatologists to be the wonder drug in acne treatments because of its effectiveness. Now, the most important side effects of isotretinoin is its teratogenicity, with an estimated risk of 20 to 35%. Isotretinoin can cause severe harm to developing fetuses, such as craniofacial defects, cardiovascular and neurological malformations, thymic disorders, and neurocognitive impairments. A well-known example of a thymic disorder is myasthenia gravis. FYI, the retinoid pathway can cause an excessive amount of cell death during organ development, and this is how isotretinoin can cause severe teratogenic effects. Now, the use of isotretinoin has also been linked to cases of clinically significant depression. Now, depression is considered a paradoxical side effect of isotretinoin, as the drug is supposed to improve psychological well-being by curing acne. So there is still quite a bit of uncertainty surrounding the links between isotretinoin and neuropsychiatric adverse effects because the supporting evidence is inconsistent. A bit about my own experience. I have taken isotretinoin before, and it was a not so pleasant experience, I have to say. Personally, I don't think isotretinoin can directly cause depression or other mood disorders, but it could amplify existing underlying conditions. I'm known to be a little neurotic. If you guys have heard of the term before, I get anxious very easily and I tend to overthink and worry too much. Before I started taking isotretinoin, the level of my neuroticism was still bearable, kind of, but it really got out of control when I was on isotretinoin. The night before a lecture I had given so many times before, I would feel so anxious that I couldn't sleep well. Sometimes just talking to a colleague I know so well gave me palpitations. I was feeling constantly irritable. I developed a very negative outlook on life in general. And at one point, I even thought about killing myself, but luckily I didn't do that. Now let's look at other side effects of the retinoids. A major side effect of topical retinoids is skin irritation, but these side effects tend to decrease with time. Some have suggested that this can be minimized by using a moisturizer which can be applied before and after a topical retinoid. This is called the sandwich method, and it essentially prevents direct contact between topical retinoids and the skin. While the method can decrease skin irritation, some have pointed out that it can also cancel the therapeutic benefits of the drugs. Topical retinoids can cause photosensitivity as well, so they should be applied at night. Now, as I have pointed out earlier, isotretinoin has a very complex mechanism, so it should come as no surprise at all that it can cause many other side effects. So I'm just gonna pick out a few to talk about here. Isotretinoin can change the microbial flora on the nasal mucosa and skin and increase Staphylococcus aureus colonization. The drug may also weaken the skin barrier, making it easier for the bacteria to enter the body, increasing the risk of staphylococcal infections. The most reported lab abnormality is serum lipid elevation. Now, despite all the potentially severe adverse effects, isotretinoin is still considered to be a safe and successful treatment for acne. You can look at this study to find out more. But of course, I don't expect you guys to memorize the findings of this study, but do note a few key points here. Firstly, treatment with isotretinoin can result in long-lasting clearing of acne lesions. Secondly, in some genetically blessed patients, only one course was sufficient. Thirdly, a really noticeable effect of isotretinoin is the suppression of sebum production, but this may gradually return to the pre-treatment or normal level after the drug is stopped, depending on the dose taken before. Interestingly, despite the return of oily skin, isotretinoin can stay effective. So decreased sebum production doesn't fully explain the long-term remission induced by isotretinoin. Perhaps isotretinoin can cause some other permanent changes in the skin or how the immune cells react to Cutibacterium acnes, and these changes make it difficult for new acne lesions to form. Topical benzoyl peroxide is a popular over-the-counter anti-acne product. It's available in different concentrations. For example, Oxy 5, which contains 5% benzoyl peroxide, and a stronger formulation, Oxy 10, which has 10% benzoyl peroxide. Mechanism-wise, benzoyl peroxide is in essence an oxidizing agent. In the skin, it is first converted into benzoic acid, which is then metabolized by cysteine to produce free radicals, which are chemically very reactive and quickly interact with and oxidize bacterial proteins. This way, benzoyl peroxide suppresses the growth of and kills Cutibacterium acnes. Topical benzoyl peroxide also prevents acne breakouts by opening up corneal site plugs and suppresses inflammation. There's been some investigation into the molecular mechanism that explains the anti-inflammatory effects of benzoyl peroxide, but the data are not conclusive. An important point about topical benzoyl peroxide is how it interacts with other topical products. It is effective on its own, but it can also be combined with other topical agents, particularly topical antibiotics, for enhanced efficacy. This is because benzoyl peroxide disrupts biofilms formed by bacteria and allows co-applied topical antibiotics to reach targeted bacteria more easily. This enhances antibacterial action and curbs the development of antibiotic resistance. With topical retinoids, the relationship is a bit more complex. It's normally suggested that they should not be applied at the same time because the combination decreases the efficacy of retinoids. An exception is adapalene, which is resistant to the oxidizing action of benzoyl peroxide. Now, the oxidizing action of benzoyl peroxide is indiscriminate, so it can also damage lipids and proteins in the skin, causing redness, desquamation, burning sensation, and skin irritation. So if there is skin irritation, you can tell the patient to stop the treatment and restart it on alternate days once the side effects has gone away. The mechanisms of action of the antibiotics used in acne treatments have been covered elsewhere, so I'm not going to talk about this in detail. Mechanism-wise, of course, they kill or suppress the growth of Cutibacterium acnes. Tetracycline antibiotics have also been shown to have anti-inflammatory effects that extend beyond their antibacterial action. Of the topical antibiotics listed here, clindamycin and erythromycin are the most popular. Topical minocycline is a relatively new addition to the arsenal of antibiotics we have against Cutibacterium acnes. As I have pointed out earlier, moderate cases of acne require treatments with oral antibiotics when topical agents fail. In the selection of a suitable oral antibiotic, tetracyclines are considered first line, but they are contraindicated in pregnant and breastfeeding women. This is because they combine calcium and potentially impair bone growth. In these cases, macrolides are suitable alternatives. The kind of last line agent, cotrimoxazole, should be used only when other antibiotics are not effective or are contraindicated. Another important point you should really know is that there have been increasing cases of antibiotic resistance. So to prevent antibiotic resistance from getting worse, topical antibiotics should not be used alone. They're best combined with other topical agents that have antimicrobial effects, such as benzoyl peroxide. This is to make sure that all targeted bacteria are going to be eradicated, leaving no room for the development of antibiotic resistance. Systemic agents must be used carefully and only when they're indicated. Shown in this table are the rates of resistance to topical and oral antibiotics used in acne treatments. Of course, I don't expect you guys to memorize the numbers. I just want you guys to understand the implications that those reported resistance rates have for clinical practice. You can clearly see here that the rates of antibiotic resistance are higher with erythromycin and clindamycin. So what can you say about this observation? Firstly, use of antibiotics in acne treatments inevitably leads to drug resistance. Erythromycin and clindamycin have been more commonly prescribed, and this probably explains the higher rates of antibiotic resistance. So, oral antibiotic therapy should not exceed 3 to 4 months, and that minimum duration of 6 to 8 weeks is required to see clinical improvement in acne patients. Secondly, this explains why tetracyclines are the first-line agents. With lower rates of drug resistance, they are more likely to be effective than the other classes of antibiotics. Topical azelaic acid has three main effects, i.e., comedolytic, antimicrobial, and anti-inflammatory. Firstly, azelaic acid unclogs follicles by decreasing keratinocyte proliferation and keratinization. This prevents the formation of comedones. For its antimicrobial action, azelaic acid is taken up into bacteria, and because it's an acid, it decreases intracellular pH. This causes energy loss and decreases protein synthesis, as a pH change affects the maintenance of the mitochondrial proton gradient, which drives energy production in oxidative phosphorylation. Azelaic acid also suppresses inflammation in acne lesions by, for example, decreasing the production of pro-inflammatory cytokines. Again, common side effects of azelaic acid are burning, stinging, tightness of the skin, just like benzoyl peroxide. The mild bleaching effects of azelaic acid can be beneficial for post-inflammatory hyperpigmentation and can help to get rid of acne scars. Azelaic acid inhibits tyrosinase involved in the production of the melanin pigments. FYI, hydroquinone, a popular whitening agent, also inhibits tyrosinase to decrease melanin production. However, hypopigmentation can occur and cause markedly uneven skin tone. I came across a discussion thread on Reddit where a user complained that azelaic acid bleached her skin and caused uneven patches of lighter skin on her face. Lastly, let's talk about some not so mainstream topical and systemic agents with specialized uses aimed at more specific aspects of acne pathophysiology. Firstly, we have topical dapsone, which has been shown to act as both an antimicrobial and anti-inflammatory agent in acne treatments. The exact mechanism of the anti-acne action of dapsone is not clear. Oral dapsone is used for the treatment of leprosy. Topical dapsone is, however, not available in Malaysia. Topical sulfur is anti-inflammatory and keratolytic. However, the evidence supporting its anti-acne efficacy is not strong. A systematic review published in 2020 found that topical sulfur was not an effective anti-acne treatment. Topical clascoterone is an anti-androgen agent. It blocks the activation of the androgen receptor by the male hormone testosterone. As you would expect, clascoterone decreases sebum production. Oral hormonal therapy is used in female patients that show specific symptoms of hyperandrogenism. What better way to counter the effect of testosterone than taking female hormones? So combined oral contraceptives such as Diane are sometimes used to treat acne caused by overly high testosterone levels in female patients. Similarly, spironolactone and metformin, normally used for other indications, are also effective against acne thanks to their anti-androgen effects. Spironolactone, quite like clascoterone, competes with testosterone for the androgen receptor. Metformin increases insulin sensitivity and subsequently activates a downstream mechanism that decreases androgen receptor signaling.